Well, welcome. Thanks for coming out today. What we plan to do today is talk about a solution offering that Sierra Systems and a number of our partners, who I'll speak to in a minute, are bringing to the Canadian market, and we're actually recently successful with in one of the large health authorities in Alberta. I'm going to talk about something called Central Station. Central Station is this consortium. It's a unique brand that we've developed, but also it's about electronic health records, the destination, and it's about how to get there through an open adaptive architecture. So I'm going to do a little bit of introduction. So I'm going to set the context for electronic health records. Then I'm going to pass it over to Sarah, who will do a presentation of Orion's clinical portal, and we'll also talk a little bit about physician order entry, disease management, and electronic discharge summaries. Towards the end, we'll come back and look at the value proposition from this solution offering, and then open it up for discussion. So in terms of who we have here today, from a corporate perspective, Sierra Systems, we're a Vancouver-based systems integration firm. Actually, what we say is we're the largest remaining Canadian systems integration firm. There's a few that are our size, but we have 14 offices in the US and Canada, and about 1,000 people, 130 million in revenue. And today, myself, I'm representing Sierra, as is Vitas. Orion Systems, leading clinical systems data integration vendor with offices in the US, Canada, UK, Australia, and New Zealand. And at the end, as Dominic said, there's going to be a competition to see which country Sarah comes from. It's Sarah Graham. Oracle is a US software vendor, whom I'm sure you're all familiar with, very large firm, 42,000 staff, over 10 billion in revenue, and really the focus for us today is around their clinical data repository product, a brand new product that's come to market called Healthcare Transaction Base. Neil Robertson was supposed to be here today. He's from Ottawa, but unfortunately couldn't make it. Unfortunately for us, he was the technical guy. So if there's technical questions and you see us running for cover, you know why. Also, as part of our consortium is another company called Quavatics. Quavatics is a US EMPI integration broker vendor, who we don't have here today, and we won't be demonstrating today. And then lastly, Hewlett-Packard, who you all know as a hardware vendor. But for today's presentation, there'll be a tablet that will be moving around through the audience that will show the same material that Sarah will have on the screen. Okay. So I'm going to talk about electronic health records for a few minutes, really electronic health record architectures and how they fit within the Canadian context, and focus a little bit on what we're calling an open adaptive architecture. You've seen this before. What is an electronic health record? Well, it's electronic. It's virtual. It holds personal information, health information, longitudinal, cradle to grave. It's organized to support care. It's accepted by a health professional, and of course there's only approved access to that record. It can include voice, video, image, and data information, and really it's primarily based around the notion of a service encounter. That's the building block. The first step in an electronic health record is really to integrate those service encounters locally. It's a complex picture, but then healthcare is a bit complex. This is an architecture actually from a large hospital organization. And over here we have the traditional investment, clinical systems, administrative systems, finance, HR, payroll. So a little bit of decision support probably going on, as well as some infrastructure, including integration brokers. That's sort of the traditional investment that's been in healthcare IT over the last 10, 15 years. The new investment is really this data repository that could take either clinical or financial data. Electronic health record type applications that take data either directly from these clinical systems or from the data repository. So it's focused in this space here. And often these electronic health record applications are positioned within another kind of technology called a portal. And that's really where we're going to be showing you today. So the second step in integrating service encounters is to look at it regionally, geographically. So many of you may have seen this picture. It was one we created when we developed the health infrastructure plan for Canada. So you have a number of source or feeder systems: pharmacy, diagnostic imaging, lab, physician office, long-term care, community clinic. And certainly in the Ontario situation, community clinic would probably include public health and community care access centres, so it would be split out a little differently. And then, of course, your hospital feeder systems. To get to an electronic health record from a regional perspective, from a geographic perspective, however large or small you decide that is, you'll definitely need some broker technology to move that data. You'll need a clinical data repository, and then you'll need an application that can view that data and organize that data for you, an electronic health record application. Where I have the red circle is really the focus of where the health infrastructure plan was, and I think we're certainly in part where CHII will be focusing its efforts over the next few years. Then, of course, we have to integrate service encounters provincially, nationally, in a pan-Canadian context. So it's now a very large geography integration challenge. Different systems. We're talking hundreds of different systems here from different vendors. Different architectures in the way these systems have been implemented. Differences in the data in terms of how it's been defined, data content. Different processes. Just doing a referral one way in Ontario may be done differently in Ontario, but it's probably done differently somewhere else. And then there's the organizational differences. Sometimes we just don't like to play together. Sometimes we do. So there's a major challenge in terms of integrating service encounters across large geographies. One of the challenges that CHII has laid down for each of the provinces is what is your architecture for electronic health records. This is an example of one that's been done by one province, which we've summarized. So down the bottom here we have all of those source systems. And as you can probably tell, it's not Ontario because they talk about regional health authorities. So you have these regional health authorities and other boards like cancer boards, etc. And they all have their source systems, physician offices. In this particular architecture, they're going to have somewhere between 5 to 10 clinical data repositories for the entire province. So there'll be some for the regional health authorities. There's some that are subject matter specific, lab, drug, and DI. And then there'll be some that take data from physician offices, physician clinics, and put those into one or more repositories. Sitting on top of this then is an electronic health services layer of some infrastructure applications like client, provider, and facility registries, consent and disclosure management, and so on. Then we have some business applications, and they come with different names: electronic health record, electronic medical summary, results viewers, disease management. All of them are trying to get at data across these multiple repositories. And then there's a presentation layer, which can be all or some of these: portals, web-enabled, or just local presentation. The key to this architecture is the clinical data repository layer. And if you don't make it open and transparent, then every application up here has to be uniquely configured to every repository. And all the data that's in that repository becomes very cumbersome and very expensive. So that's sort of the geographic view of the world. What we also wanted to look at was more a proprietary versus an open view of the world. So in this case we have, some of the large hospital information systems where different geographies will try and have a core set of functionality from a vendor to try and get some integration going. Whether it's McKesson or Meditech or Cerner, every one of you have bumped into them. And there'll be different flavors of systems in long-term care, public health, etc. If I'm a physician and I'm sitting out in my office and I have a patient and I've referred them to the local community hospital, and then they got referred on to another facility or a specialist, and then they get maybe sent to Toronto to a quaternary institution, If I wanted to look at my electronic health record, not even that, if I just wanted to look at some hospital information about that patient, I would have to get access to probably all of those systems. That by itself is very expensive and prohibitive technically to do. So what that forces, a proprietary solution basically forces you to get every solution that you need about your patient on your desktop. Doesn't happen. Oops. So what we've, as part of the central station solution, are switching out that layer and putting in a normalized data repository based on a known standard, HL7 version 3 RIM, Reference Information Model. It's published, everybody knows what it is. And then on top of that data repository, you can have Java applications that would do things like searching for a patient, managing consent, recording encounters, providing results, and so on. And what we're going to do is show you some of the solutions at that layer. So the repository, again normalized based on HL7 version 3 RIM, has a full set of a terminology loading service, so you can load, and it has preloaded ICD-9, 10, SNOMED, LOINC, those kinds of terminologies, but you can load your own custom terminologies if you wanted to. The importance of that is with this particular repository, it ties all different definitions to one concept. Example, you have a term called an immunization, a vaccination, and an inoculation. They're all the same thing. If you say the concept here is a jab, then when it looks for a jab, it'll bring up all those inoculation, immunizations, and vaccinations, that data. It also has full messaging services in and out, so you can go two-way messaging. Has the APIs to build over the repository, full security and auditing services, an EMPI to rationalize identities, as well as some other functionality. And then you build either commercial or custom applications to sit on top of the repository. The repository is the Oracle product, HTTP. The applications that are getting built, and the one we'll show you today, which is a commercial application, is from Orion. Orion can work against that repository directly, or it can work against the source systems directly, and it really depends on the volume and complexity of your data, whether you've moved to a repository or not. Similarly for Sierra and Oracle, we provide the implementation services as well as building some custom applications on top of this repository. So you ready? So we're going to now switch over to, we've got a little bit of technology here, switch over to a presentation of, oops. Data show.